Hello and welcome to Everyday Oral Surgery. This is your host, Dr. Grant Stucki. I am an oral and maxillofacial surgeon practicing in Denver, Colorado. The goal of this podcast is to connect, learn, and inspire. In this podcast, you'll be hearing from OMS surgeons all over the globe discussing ways to improve the practice of oral and maxillofacial surgery. Most information shared in this podcast will be based on personal experience and opinions, so please supplement what you learn here with approved research studies. Without further ado, please enjoy today's episode. All right, welcome to another episode. Today I'm with Doctors Andrew Jenzer and Maxwell Lloyd. We are continuing our Heme kind of series where we're talking about all things blood related. So we really appreciate you guys joining us to talk more about some pathology related to the blood.
Hey, good morning, Grant. Happy to be here again. Before we kick off, usual disclaimer, please verify all this information for yourself before applying it in a clinical situation. AMIS is coming up, the national meeting in September. I will be there all week. If any of our listeners, I know Grant and I usually hang out a little bit there, please come and say hi. We love to hear from folks. And the St. Louis course, October 9th through the 11th. Check it out online. It's the best boards review course. I'll be there teaching medicine and would love to see you there. But today we would like to kind of do the other half of the last episode. And instead of focusing, previously we did leukemias, we would like to focus on kind of lymphomas and multiple myeloma. So kind of the sister podcast with the last one. Max, you want to kind of start us from the jump about lymphoma basics?
Yes, absolutely. So as you mentioned, this is a continuation of the last podcast, sort of part two, where previously we talked about leukemias and now thinking about pivoting to lymphomas, which are largely a malignancy of lymphocytes. And most often we see them arising in the lymph nodes, but this is also a blood cancer. And for better or worse, there are two large buckets of lymphoma that we can start to talk about. One is Hodgkin lymphoma, and the other is a very broad sort of catch-all non-Hodgkin lymphoma. And so first diving into Hodgkin lymphoma or classical Hodgkin lymphoma, which often presents with painless lymphadenopathy. People will notice swelling in the neck, lymph nodes that have been growing slowly or more quickly. And also it often presents in the mediastinum in patients, which may not be as clinically apparent immediately, but on imaging, we see mediastinal involvement relatively often. And with classical Hodgkin lymphoma, one of the typical associated cells that's often pathognomonic for this condition, if you hear it as sort of a buzzword, is the Reed-Sternberg cell, which after a biopsy on histopathology, you will see this binucleated cell with, quote, owl eye nuclei, and it's got a pretty characteristic picture of that cell in as an isolated cell in an immune milieu on histopath that really helps cinch a diagnosis of Hodgkin's lymphoma. And we'll often see that these cells are CD30 positive and CD15 positive. So that helps us confirm that these are in fact Reed-Sternberg cells, not just by their appearance, but also by the markers that the cell expresses to help us confirm a diagnosis of classical Hodgkin's lymphoma. And there are typical presenting signs and symptoms, and then workup of this condition. Drew, I didn't know if you wanted to take us through a few more steps in how we're thinking about these initial cases of Hodgkin's.
Yeah, and I'll touch on this briefly, but I've actually seen a fair amount of lymphomas recently. I biopsied at least 3 that came back as lymphomas in the last year, which is kind of scary. But a big point of this is the clinical exam. There's common board questions in our field that come up. For example, kind of what is the sensitivity of doing a head and neck exam? Like what can you pick up? And the answer is for at least, broadly by the literature, even oncologically trained surgeons can pick up on a clinical exam a lymph node of 1 centimeter or more about 75 to 80% of the time. But we start to think about these lymphomas, they will often present with lymphadenopathy in the head and neck. This is something I think about as I'm doing my head and neck exam on everybody, palpating the lymph node chains, looking for asymmetry or enlarged lymph nodes. So, file this in the back of your mind if you can find some of those things sometimes. But similar to our other things, just briefly, the presenting stuff is things like fever, weight loss, night sweats, we call these B symptoms. And this patient's going to go through, extensive workup with probably biopsy, PET scans to try to look and see where, increased areas of metabolic activity on. And then we kind of get into staging and risk stratification, which is constantly evolving. But with a broad picture, generally stage 1 and stage 2 disease, which is early disease, tends to be on just one side of the diaphragm, while stage 3 and 4 disease, more advanced staging, a little bit worse, tends to involve both sides. And then as we start to talk into treatment a little bit, Max, I'll obviously defer to you as an expert in this field, if you want to take over.
Yes. I just wanted to tag that the staging system is called the Ann Arbor staging system. And so that might be a term that people hear, but it's that same side of the diaphragm, either a single lymph node, stage 1, or multiple lymph nodes, stage 2, both sides of the diaphragm, lymph nodes, stage 3, and then more disseminated into extra lymphatic organs, the lungs, the liver, other organs as a stage 4 disease.
This might be kind of stupid, but the way I remember this is an owl at Michigan football stadium. So an owl, binucleated owl cells in, the Ann Arbor, Michigan. So that's my stupid way for remembering this. A little owl at watching Michigan play, Ohio State or something.
Love that. And I also just wanted to tag for the diagnosis, especially in Hodgkin's, we need a lot of tissue, big amounts of tissue. So either an excisional biopsy where you take out a whole piece, or something we call lymphoma protocol, where you have many, many core biopsies, but we really want to see those Reed-Sternberg cells, and they can be a bit tricky to find. And so tissue, often we say tissue is the issue. We need a large chunk of tissue for diagnosis of all lymphomas, but Hodgkin's is very important to get a good biopsy. But as you said, the treatment for Hodgkin's, as with many of these malignancies, is rapidly evolving. There's new therapeutic paradigms being introduced, and the field is moving quite quickly. So we'll talk about treatment in broad strokes and think about some of the high points, but understanding that there's a lot of evolving literature and research where new therapies are being introduced into standard of care paradigms. And so it's important to know that we think about some of the classical ways to treat this condition, but things are changing pretty quickly. And there are slight differences in treatment, whether it is in that early stage or that advanced stage when it's first diagnosed. And so for the early stage disease, classically, Hodgkin's has been treated with a chemotherapy backbone called ABVD, another series of letters, which each one stands for an individual chemotherapy, where it's adriamycin, which is an anthracycline, bleomycin, vinblastine, and dacarbazine. And then this is with or without radiation. And the treatment of early stage Hodgkin's lymphoma is a little bit complicated because the number of chemotherapy cycles and whether or not you implement radiation and what dose depends on several factors. Is the risk favorable or unfavorable? And while you're treating them, do you see disease response on PET scan during interval cycles? And so everybody's treatment is a little bit individualized in that way, but often the backbone is with this ABVD regimen with or without radiation therapy. And when you think about advanced stage disease, stage 3 or 4, where it's on both sides of the diaphragm, the prior standard of care was ABVD, for 6 cycles. However, there's been newer regimens that have been integrated into practice that have shown not only better outcomes, but also favorable toxicity. Because bleomycin in the ABVD regimen can have a lot of problems associated with it. Specifically, bleomycin is a menace because it causes lung toxicity, and it can be just generally a very challenging drug to tolerate. And so there was something called the Echelon-1 trial, which looked at a regimen called BVAVD, where they dropped the bleomycin and they used something called brentuximab vedotin, which is an antibody drug conjugate, where you take a chemotherapy payload, you attach it to an antibody. That antibody is essentially acting like a homing missile for a specific target on the cancer. And so in this case, it's a monoclonal antibody against CD30, which we know the Reed-Sternberg cells are CD30 positive. So the idea is it delivers this higher chemotherapy payload directly to the cancer, potentially minimizing off-target toxicity and improving outcomes. We saw that it was better than ABVD, but vedotin and vinblastine are both microtubule inhibitors. And so they have overlapping toxicity. And so we saw some issues with higher, specifically peripheral neuropathy with that regimen, which was a limiting factor in a lot of patients. But more recently, another trial demonstrated that nivolumab with AVD as a way to drop bleomycin or replace brentuximab vedotin, that with nivolumab, which is an immunotherapy, an anti-PD-1 with AVD, showed very exciting anti-tumor activity, and that the outcomes as well as the toxicity profile were more favorable compared to ABVD and the brentuximab vedotin AVD, where Nivo AVD has largely become a new standard of care in these advanced stage Hodgkin's lymphoma, both for better outcomes and often better toxicity profiles. But these other regimens are approved and utilized in different clinical scenarios. But the utilization of immunotherapy in Hodgkin's lymphoma has becoming more and more common, and we've seen some really exciting efficacy with that approach. And when I'm saying early stage or advanced stage, all of this is with curative intent. Even if a patient presents with Hodgkin's lymphoma on both sides of the diaphragm with disseminated disease, we know that lymphoma, Hodgkin's, and other lymphomas are very chemotherapy responsive. And so this is a cancer that, even if it's advanced stage, can be cured with chemotherapy up front.
Nice.
Nice. Max, one of the most impressive things about listening to you talk is your ease of going through all the crazy cancer drugs and your pronunciation. So I have a lot of FOMO. It's really impressive.
That's how I feel listening to you guys talk about surgery.
Nice. And then, so let's dovetail this into the broad category of the everything else bucket, the non-Hodgkin's lymphomas, right? This is a very large heterogeneous group of disorders. Some examples include things like diffuse large B-cell lymphoma, follicular lymphomas, mantle cell lymphomas, maltomas, Burkitt's lymphomas. There's a lot of them. And about 85% of these are B-cell origin. Generally, these can be characterized as low, intermediate, or high grade and present with the same kind of symptoms that we talked about. These also can present in the head and neck. And so a lot of different things, different subtypes and things, and T-cell lineage and some other stuff. In terms of treatment strategies, again, Max, highly complicated, ever evolving, but chemotherapy remains the mainstay of treatments because, like you said, they're very responsive to chemotherapy. Something I always think about is these patients are often get radiotherapy as well as part of it, which, as we know, can cause long-term sequelae in the head and neck, right? Incidents of things like sarcomas and osteosarcoma, which are horrible, and the few times I've found have been scary as somebody who doesn't treat malignancies. Let's see, Max, you want to kind of dive a little bit more into painting some of the pictures of the chemotherapies for these?
Yes, certainly. And as you had said, this is a catch-all bucket, which I think is a bit of a relic of the past of how we used to think about lymphomas, but calling something a non-Hodgkin lymphoma is often very unhelpful because it's, I like to think of thinking about what's your shirt color. If you say that shirt is black, you know it's a black shirt. But if you say it's not a black shirt, that shirt isn't black, well, what color is it? There are many colors or flavors of non-Hodgkin lymphoma. And so the approach to something like a diffuse large B-cell lymphoma or a DLBCL is very different from a follicular lymphoma, where a high-grade non-Hodgkin lymphoma like DLBCL is going to be rapidly proliferating, often needing urgent treatment, and is very responsive to chemotherapy because these cells are rapidly dividing, versus something like a follicular lymphoma, which is generally pretty indolent. You have some slow changes in lymph nodes over many years, and this doesn't respond to chemotherapy because the cells are not rapidly dividing, and these are often patients that don't need immediate treatment, that you can monitor. If there's changes, you can start to institute B-cell directed therapies or more gentle anti-cancer agents, but just a very different approach than something like a high-grade lymphoma. But DLBCL is the most common high-grade lymphoma and is often what we'll be seeing in the hospital setting because it grows quickly, it causes patients problems, and it lands them in the hospital requiring more urgent intervention. Again, even if it's disseminated, can be treated with curative intent with chemotherapy, even if it's spread throughout the body, which by nature of being a blood cancer, it often is throughout the body. But these cells are so rapidly dividing that they're very sensitive to chemotherapy. And the tried and true regimen that people may hear for DLBCL has always been CHOP or R-CHOP, where the CHOP stand for cyclophosphamide, doxorubicin, vincristine, and prednisone. The letters are a little confusing, like vincristine is the O, but it's Oncovin because the brand name. So maybe just to make that cool acronym work. And then the R, it stands for rituximab, which has been incorporated into the standard treatment for a lot of these B-cell lymphomas as a B-cell directed therapy. But R-CHOP has been a standard of care for many, many years and has been shown to be reasonably tolerated and have great efficacy rates. There has been a new regimen called polatuzumab R-CHP, where polatuzumab vedotin is another antibody drug conjugate, this time against CD79B, that has shown better progression-free survival, and so is starting to be more incorporated into the treatment of patients with higher risk disease. But often R-CHOP is used for the treatment of these folks. There's also risk stratification that we think about. Something that people may hear is called double hit lymphoma. And the idea is that the lymphoma harbors a MYC translocation and a concurrent BCL2 or BCL6 translocation. And the idea is the MYC translocation is sort of the gas to make the cancer proliferate more rapidly. And then BCL2, BCL6 is the brakes, which if we lose our ability to induce apoptosis, that can promote these high-grade lymphomas from growing more rapidly. And when you have both together, they call that a double hit. And it's more aggressive. It confers worse prognosis. These are some people that might get a regimen called EPOC, which is adding a topicide to CHOP, although that can be institution and sort of case specific. But know that double hit lymphomas are bad and often are worse prognosis in terms of outcomes.
And I will say one of the super tricky things about this, and especially if you're a surgeon like you and I, Grant, who don't do malignancies, is that there are so many subtypes in this with varying treatments, some of which may involve surgery, some not. It's beyond my scope. the three that I've biopsied this year, one was a high-grade Burkitt's, and a couple were like diffuse B cell. And clinically, one of them was kind of like there was no bony involvement, but they had a very large soft tissue swelling that was like one side of the maxilla. And you're like, okay, is this an infection? It's very firm, it's non-tender. And that and another one, when I cut into it and to biopsy a large piece, it kind of reminded me of like a high chew candy. It was kind of whitish, pale, didn't really bleed, and just odd. So, if you're having stuff that isn't explained, sending a large sample, but that was kind of what it looked like. But because I don't do that, I'm not sure which ones an oncologist would treat with all these subtypes and more being elucidated. But I think an important point is what you do with that. Put yourself in that patient's shoes. I would want that doctor to bend over backwards to get me into care as fast as possible. So I kept the patient in my chair. I physically myself I grab my resident team. We go over to talk to the oncologist in person. Hey, this is what we have with this diagnosis we just got back. How can you help? We want to make sure this patient is in your purview and care as soon as possible. So really, please, if you get a diagnosis back on one of these biopsies, bend over backwards to provide as much information. I always take pictures before and during biopsies of weird things in the event they are cancer to help provide the next level of care with better. But you want to be, doing everything you can for this patient when you get these weird diagnoses back, because there can be a lot of implications and we want to help rather than hurt with that. You have any thoughts about that, Grant, in terms of weird biopsies you've done or results kind of stuff in your practice? I don't know how much stuff like that you're seeing or doing.
Not a ton, but I was going to ask as far as things that predispose people to these types of cancers. I mean, like Hodgkin's lymphoma isn't like a prior episode with mono or the Epstein-Barr, these things, viral type things. Can those cause the non-Hodgkin lymphomas as well, or what are the risk factors?
It's a great question. Generally, we don't have any clear risk factors that we know are going to predispose somebody to the development of one of these non-Hodgkin's lymphomas. I'm sure there is genetic components that we haven't fully elucidated, but there's no clear hereditary patterns in a lot of these. It's not predominantly associated with lifestyle, obesity or alcohol or other risk factors that we might think of in some solid malignancies. And so with Burkitt's lymphoma, there is an association with EBV, and I think also with HIV as some viral predispositions in terms of triggering Burkitt's. But when counseling patients with a new diagnosis of non-Hodgkin's lymphoma, something like diffuse large B-cell lymphoma, we often talk about that there was nothing specific that set them up for this. When you're rolling the genetic dice or the lottery, there's a lot of things that you roll that go right, but sometimes things go wrong, and this seems to be one of those conditions that's really, as far as we know, not associated with specific heritable or environmental risk factors. That often is just bad luck for the development of one of these.
Okay, that's helpful. Thank you.
Nice. I do want to touch on next something that I had to deal with once that's kind of in this world, and if you're not familiar with it, it can kind of bite you, is tumor lysis syndrome. And so when we're talking about especially more advanced or rapidly dividing or aggressive cancers, things like high-grade lymphomas, or other even things like AML or ALL with high blast counts, it can put you at risk for this. And if you think about the pathophysiology, what we're talking about here with tumor lysis syndrome is somebody has one of these malignancies, they start to get chemotherapy. And oftentimes, and Max, I'm not sure about when you would make this decision, but what I've seen, being in the ICU is that a patient will get admitted to the ICU at least for a day as they start chemotherapy. Because as you start to go in there with a blowtorch and kill cancer cells and the cells lyse and get destroyed, well, they release all of their contents. And in particular, this can set you up for really severe electrolyte imbalances, these spiking levels of things like phosphorus, potassium, uric acid, and other things. And, if the listeners, if you're thinking through, what do I do when certain electrolytes are too high, right? Hyperkalemia, hypernatremia, you have these algorithms. Particularly phosphorus is a kind of hard one because there's not much you can do. It's pretty much, dialysis or bust. There's not like things you can do to really lower the phosphorus well. But Max, can you kind of just tell us things that we should be aware of with tumor lysis syndrome generally?
Yes, and especially with these high grade lymphomas like Burkitt's or bulky DLBCL, when you're starting these anti-cancer treatments, you have this rapid cell turnover. That's a patient that is set up for possible tumor lysis syndrome that you need to be monitoring closely and thinking about the development of this as a potential complication. With TLS, we often think about both a laboratory criteria as well as a clinical diagnosis of TLS, where the laboratory criteria, you really are thinking about those specific laboratory derangements of uric acid greater than 8, potassium greater than 6, phosphorus greater than 4.5, and then calcium less than 7. So it's everything else is high and the calcium is low. And this is driven by cells dying and spilling their intracellular contents, and leading to those laboratory derangements that you're picking up on, where a clinical diagnosis of TLS is all of those laboratory criteria. Well, really, you want 2 or more of those laboratory criteria. And then either elevated creatinine, so an acute kidney injury, or something like a cardiac arrhythmia, which is often driven by high potassium. People can have seizures or even death. And the combination of a laboratory changes plus the clinical diagnosis is often what we're worried about with the evolving TLS picture with these laboratory derangements, and is why when we see those changes in the uric acid, potassium, phos, we want to implement intervention early. And a lot of treatment for something like a diffuse large B-cell lymphoma, we start patients on prophylaxis when they're starting their chemotherapy regimen to prevent this from happening. Things like giving lots of fluids. We want people to maintain a robust urine output and get rid of those cells that are being turned over to excrete uric acid and phos as optimally as possible. We will start them on allopurinol prophylactically before the initiation of chemotherapy to keep that uric acid low. And then we also have something called rasburicase, which can rapidly decrease uric acid. It's important to know that rasburicase is contraindicated in G6PD deficiency. It can lead to hemolysis. And so we check G6PD in all of these patients as soon as they hit the door, anticipating that they might need chemotherapy. And then, as you mentioned, a last resort is often renal replacement therapy or dialysis. If the kidneys are not able to keep up with the filtering of these intracellular contents being dumped, then we'll need to ideally temporarily start these patients on dialysis to get them through the weeds.
Nice. Let's dovetail this into kind of the last bolus topic here, multiple myeloma, something that we actually see. I don't know. I feel like I see a fair amount of patients who have this or issues subsequent to it. And remember, team, obviously with a lot of these conditions, bisphosphonates are a real thing. We're not going to talk about that today because that's a whole separate topic. But generally, multiple myeloma is a malignancy characterized by the neoplastic transformation of plasma cells producing a monoclonal immunoglobulin, which is AKA like an antibody. And you get proliferation of this in the bone marrow, and then you get osteolytic lesions, hypercalcemia, osteopenia, and then pathologic fractures are kind of those common clinical features leading to things like renal failure and anemia. Now, a really important point is, multiple myeloma does not exist in a vacuum. It exists on a spectrum of things that we don't talk about that much, like MGUS, right? Monoclonal gammopathy of undetermined significance. So, Max, would you mind just kind of helping us understand the spectrum of this disease and kind of the progression through? Because sometimes if we get a disease like this on the medical history, it's going to help us understand what that means and where it's going a little bit, because those have implications about potentially us providing care currently or in the future to those patients, if that makes sense.
Yes, absolutely. I think it's a really important and nuanced topic of the spectrum of monoclonal gammopathies, where we have this entity called monoclonal gammopathy of undetermined significance, or MGUS, which we know has a certain chance of progressing to something called smoldering myeloma, which then has a certain chance of eventually progressing to frank multiple myeloma. And often the progression through these stages takes time, and we might catch a patient at one point or another in this evolutionary journey, but that not all MGUS progresses to multiple myeloma. And this is a pre-malignant clonal plasma cell population that is detected in the blood, that is going to be clonal plasma cells that often are secreting either IgA or IgG immunoglobulin, and that can either be kappa or lambda light chain restricted. So you'll see it designated as IgG kappa or IgA lambda, just in terms of the terminology that you'd see. But MGUS is very common, and it often may never cause problems to somebody in their lifetime. So it's estimated, it's likely underestimated, but it's estimated about 5 to 10% of people will have MGUS by the time that they're 80 years old. And it's naturally something that occurs in an older aging population as opposed to younger patients. But we can find MGUS through lab tests, blood tests, that wasn't causing somebody problems and will never cause them problems in their lifetime and doesn't require treatment. But with MGUS, there is a 1% chance per year that can progress to smoldering myeloma, which then carries a 10% risk per year of progression to frank multiple myeloma, which does require treatment. And so that spectrum is important to know about. And talking about somebody with MGUS, thinking about their risk of eventually developing a malignant condition like multiple myeloma that will require treatment, and how to think about monitoring them in an appropriate way to keep an eye on everything and make sure that we're acting swiftly if needed, if treatment is required. But also, this can be MGUS can be a condition that's associated with a high amount of anxiety, because the treatment is observation. We're not going to give you anything. We're just going to keep an eye on it. And that also can often be challenging for patients who may be more eager to do something or take care of it. And so that can be a nuanced discussion about the fact that this may never cause you problems in your life, and we'll just keep an eye on it, but act if we need to.
Kind you. Yeah, I think it's helpful to understand that multiple myeloma doesn't exist in the vacuum, which is a misconception I see a lot. It's important to understand there's a kind of spectrum here. In terms of these patients, let's just focus on kind of multiple myeloma. So we talked a little bit about some of the signs and symptoms. The classics, just to mention it: hypercalcemia, right? You get the stones, bones, abdominal moans, and psychiatric overtones or groans. The things that can manifest with that when you have that bony destruction. And obviously bisphosphonates can play, or similar medications can play a role in this. But when we talk about cure, I think a big important thing to highlight is there is no cure for a multiple myeloma, right, Max? It's an uncurable disease. So we can just try to bring it under control and, control the symptoms, but we can't fix it. Is that right?
Yes.
Yeah. So when they have it, they kind of have it forever. Can you just broadly speak about some of the medications that you guys use to manage somebody with multiple myeloma?
Yes, absolutely. I do want to take a minute to just go through testing and diagnostics quickly, because I think
Sure.
that this can be a little bit of a potentially confusing topic that might be helpful to hear at least some terminology. But there's a lot of laboratory studies that we can get to assess for MGUS, smoldering myeloma, or multiple myeloma. And often that involves getting something called an SPEP, or a serum protein electrophoresis, and immunofixation electrophoresis, or IFE. And that helps us to assess the M protein, the monoclonal immunoglobulin burden. So we can see how much monoclonal IgA or IgG there is. And that's the M spike that we see. And it's reported as grams per deciliter. We'll get a serum free light chain assay to assess their kappa, their lambda, and the kappa to lambda ratio. And you will see a skew towards either kappa or lambda, depending on what the malignant clone is producing. You can also get a urine protein electrophoresis to look for Bence-Jones protein in the urine. And so you'll see these monoclonal light chains being filtered and being dumped into the kidney.
Common test question right there. Bence-Jones proteins in the urine. Highlight for the listeners.
And we can get quantitative immunoglobulin levels, so you can see quantitatively how much IgA, IgG, and IgM there are. In a lot of cases, if there's concern for smoldering or multiple myeloma, we can get a bone marrow biopsy to assess what is the burden of clonal plasma cells that are in the bone marrow. And then imaging, we can get a skeletal survey or a CT or even a PET scan to look for bone lesions that can help define multiple myeloma. And a diagnosis of multiple myeloma is made classically either if there's over 10% clonal plasma cells in the bone marrow and someone has symptoms. So those are the CRAB symptoms, the hypercalcemia, kidney problems, anemia, or bone lesions. So those together, you can make a diagnosis of multiple myeloma, and which, again, as we talked about, would necessitate starting an intervention. Or there's also some of these, what they call slim CRAB criteria, which any of these things alone can make a diagnosis of multiple myeloma. So if you have over 60% clonal cells in the bone marrow on biopsy, that enough is alone. Or if the serum free light chain ratio, let's say the kappa lambda ratio was over 100, that over 100 light chain ratio is enough to make a diagnosis. Or if you have more than one focal bony lesion on MRI, that the multiple bony lesions is enough to make a diagnosis of multiple myeloma. And then once you have the diagnosis, there's a whole risk stratification system where you use cytogenetics, other laboratory testing, age, performance status to think about high risk versus standard risk myeloma. But commonly, treatment involves either a 3 or 4 drug regimen or induction, and then patients may or may not get an autologous stem cell transplant, just depending on risk stratification and their fitness, if they're transplant eligible. But a common combination for induction treatment is something like RVD, so a drug, bortezomib or Velcade, which is a proteasome inhibitor, with lenalidomide or Revlimid, which is an immunomodulatory agent, and steroids. So dexamethasone is the D in the RVD. And more recently, often daratumumab, which is a monoclonal antibody against CD38, is being incorporated into this backbone as well as the 4th drug. So daratumumab RVD or Dara RVD is a very standard 4-drug regimen that people will use for induction. And just a few common side effects with these medicines: bortezomib or Velcade often has peripheral neuropathy that can come up. Revlimid, we worry about blood clots, and so patients will be on a daily prophylactic aspirin with this. And so if somebody needed to stop their aspirin for a surgery, we have to be conscious of also talking with their multiple myeloma provider about taking a break from the lenalidomide, because if you're taking the Revlimid while holding the aspirin for an anticipated surgery, it would increase the risk for developing something like a DVT. So just being mindful of that as a potential side effect with that medicine. And then on this 3 or 4 drug regimen, once you get them you give them a certain number of cycles, say 4 cycles, to induce a remission, you can decide to either take them to a consolidation autologous stem cell transplant, where you take their own cells, you give them a substantial dose of chemotherapy, and then you rescue their bone marrow with their own cells, and then continue a patient on maintenance therapy. Or you can forego autologous stem cell transplant and just continue a patient on a maintenance regimen, either a 1 or 2 drug maintenance regimen, to keep them in remission. Another medicine that we sometimes see is cyclophosphamide, or Cy/Bor-D, which Revlimid is, you can't give it in somebody that has acute renal failure or very bad renal function from new multiple myeloma. So sometimes that's a regimen that we utilize in the hospital for new cases with substantial renal involvement, which is not too uncommon if somebody's hospitalized for this. And then another part of standard multiple myeloma therapy is going to be using an anti-resorbative agent for lytic lesions to decrease the fracture risk. So that will either be bisphosphonates or denosumab or Xgeva. And these are part of the standard regimen for multiple myeloma treatment that we're giving patients every month to help decrease the risk of fractures and bone problems while they're going through treatment.
Yeah, and obviously a big thing in our world. The smartest person and a guy I did a lot of these end-stage MRON cases with is Ben Heckler. I know a frequent guest in your podcast, Grant, but high recommendation. If you want to really learn about MRON, Ben is the one of the best guys to ever do it, because it is hard. The evidence is not great, and there's a lot of options about how you do it. Clinically, I have been as recently as a couple months ago in this situation, so I want to highlight it. Maybe also malignancy, maybe not, but probably some sort of something in this world, an anti-resorptive agent, and they have some sort of issue that either is looking like an osteomyelitis or a new concerning lesion, usually in the mandible. And you're thinking, okay, is this MRON? Is it a new malignancy? Is it a new focal concentration of multiple myeloma? But don't forget that if you do have multiple myeloma, you can get these new collections of cells that will essentially present like a malignancy. And the only way you figure that out is by biopsying it. But you really have to be thoughtful when you're working through these sick patients with these stacks of issues about what potentially can it be. I do a ton of frozen sections in the OR where I take a piece, I go down and look at it because I'm a nerd and I love histopathology with my path team, and help guide what I'm going to do in surgery based on that immediate answer. Obviously, at an academic center, that's a lot easier with a dedicated oral pathologist and others. But I always go into those surgeries with a plan A, B, C. If it is this, what am I going to do? What if that doesn't work? But it can be really hard when you're thinking about looking at this long medical history, and especially multiple myeloma and these concerning lesions, and what you do about it. So don't forget that it can be a new concentration or a collection of, those cells in the, typically mandible, but somewhere in the craniofacial skeleton. Let's see, Max, let's just wrap up. I just want to touch on the big points one more time. So if a patient has a history or active malignancy, especially like here we're talking about hematologic, but talk to the oncologist, get as much information. Like I was highlighting, a lot of these things, Max mentioned them today, right? Adriamycin, right, has cardiac problems and can lead to heart failure and issues. Bleomycin on all the nasty stuff with the lungs that can affect things like nitrous oxide use, general anesthesia. You got to figure out as much information as possible so you can safely make decisions moving forward. Ask for all the treatment notes and records, right? You'll get a huge consult thing back, but take your time reading through them. Ask questions. If they've had radiation, get dose mapping. and really think about those chemotherapeutic effects on the multiple organ systems that might adjust or change your plan. And especially immunosuppression, right? These are not healthy people. Max, I don't know if there's a part of this or cutoff, and we're talking about spectrums when you generally consider patients immunocompromised, but if they're in this world and dealing with these issues, generally I'm going to, be much more judicious with things like antibiotics around surgery and doing everything I can to mitigate an infection happening. Um, what do you think? What are some things or thoughts that we can do as oral surgeons to better, hopefully these couple lectures built a better understanding or a deeper understanding, especially about reaching out and working as a team. But do you have any thoughts or things you'd like to see better from us that would make the communication piece better?
I think that everything that you're touching on is really important and is sort of the cornerstone of collaborative patient care across multidisciplinary settings in order to really ensure that patients are being treated promptly and taking their medical history and what they're going through into consideration when thinking about how serious or how urgent or when can we intervene. But knowing that somebody not just has cancer, but what type of cancer and what anti-cancer therapies they're on, I think can really change the calculus in terms of how serious we need to take something. If somebody has a what we talked about from our last podcast, something like a chronic lymphocytic leukemia, or say in the lymphoma world, a follicular lymphoma, something that's maybe more slowly growing, indolent. They're either being just observed or on a single targeted oral therapy. That is a very different circumstance than somebody with a high grade, rapidly proliferative, say, diffuse large B cell lymphoma requiring multi agent chemotherapy, where in the first case, you might see the word leukemia, but it's a very different patient and should be thought of and treated differently in terms of our concern for immunosuppression or infectious complications, where somebody on, say, an RCHOP regimen being treated curatively for a diffuse large B cell lymphoma, I like to tell my patients, if you're reaching for the thermometer to check your temperature, reach for the phone too, because fever is scary. And in these patients, when their neutrophils bottom out and they're neutropenic and highly susceptible to any type of an infectious process, it's important for us to know about it. So I would say that the threshold to reach out should be incredibly low in those circumstances. In which case, if we're worried about some type of infection in the mouth or anything that needed any type of operative intervention, it'd be incredibly important to have the oncology team and the oral surgery team in close communication to understand, is my patient at what we call the nadir? Are they at their lowest neutrophil count from the chemotherapy? If we gave it between 7 and 14 days ago, my worry is that their neutrophils are going to be essentially zero, and that's when they're at highest risk for infectious complications. Do we need to think about delaying the start of the next cycle or any type of operative management? We always like to say, if it's for curative treatment, it needs to be full dose and on time. But there are, of course, extenuating circumstances where that might not be possible. But working with surgery teams or other multidisciplinary teams to deal with issues that come up as promptly as possible in order to continue their chemotherapy full dose and on as time as possible to work towards that cure, I think is super, super important. So we would like to keep people on a certain rigid schedule, understanding that that might need to be moved depending on the issues that arise, but that not every cancer and not every anti-cancer therapy is the same in terms of its impact on the immune system. So those pieces, I think, are very important in that multidisciplinary discussion so that people get a sense of, well, what is the risk here and how promptly do we need to intervene because of the potential impact on their treatment regimen.
That's awesome, man. It's making me think about how like a majority, pretty much, I have great residents in my residency, right? But pretty much all the problems that we have can be boiled down to not communicating as well as they should, right? Collaborating with sorting providers, all the consults and everything, each other, the operative teams. Sometimes I feel like communication is just like it all comes down to that. Because if you can do well at that, like you're talking about, then you can really understand things and do the right stuff. Grant, any final thoughts from you?
No, this has been a good review of the lymphomas, tumor lysis syndrome, multiple myeloma. I mean, any recommendations that you guys have for listeners that want to learn more about this, of like literature or sources of information that listeners could go to learn more about this stuff?
But before Max answers, I think in our world in particular, unless you're doing a fellowship in this, you're not going to be expected to know all these inside and out. But this foundational understanding is important. Looking into the surgical pathology aspect of it is really helpful as a resident and a learner. The Marks book does a particularly good job of that. A lot of the other path books, unfortunately, like they go through stuff, but they're written by pathologists who aren't surgeons. So figuring out a source from a surgeon to understand that is a critical part of all this pathology learning. And particularly like mentorship or asking them, if you're at a training at a place or working with folks, just digging into their brains and mind, going to tumor board, being part of that process. What about the other side of it, Max, just from like other sources that you might know or have from the more medicine side?
I think anytime you want a general view of the topic and at least a quick summary up to date is a great gold standard. They have terrific information curated by experts. There is expert opinion in up to date, but as a go-to resource, especially reading the summary recommendations to get an initial sense of some of these topics, and then you can read a little more in depth, up to date, I think is fantastic. And then if there's curiosity about even more detailed information or where some of these recommendations might be coming from, the gold standard in the oncology world, in a lot of cases, is the NCCN guidelines, where NCCN has curated guidelines and treatment standards for each individual type of both solid and liquid malignancies, as well as ASH has great resources to refer to. But the NCCN guidelines collate current research standards and practices to provide specific treatment recommendations based on literature, and have it broken down not only by malignancy subtype, but then subtypes within that. And so if you were ever curious about where the national standards and practice guidelines for oncology come from, NCCN is a terrific resource and is often what oncologists use to help determine best standard of care treatment plans for patients. And those
Actually,
are
Max, let me, we weren't talking much about oral carcinoma, but just like myself, and I have all my residents do it, you can go to NCCN, I think it's .org, I forget, if you Google it, you can make a free account and you can access, and you really should, all the residents out there and learners, go make that account and then download and look at the specifically the head and neck or oral squamous carcinoma. Because it's about a couple hundred pages, but you don't have to know everything on there. Near the bottom of those slides, they give actually written explanations of everything. What's the definition of a clear, close, and positive margin? There's literally all the answers you need to not only understand things, but to answer all the test questions. You have a cancer. What do you do? The answer is just this one slide in NCCN, right? You do a nasopharyngoscopy, you present it to tumor board, you get these labs, you get imaging in the chest. So it gives you all the answers, and it's updated maybe 2 or 3 times a year from all the experts. But if you're not familiar with that, definitely explore it and find those couple of gold slides with really, we need to understand carcinoma, maybe not the weird head and neck cancers unless you're doing that, but it is by far the best resource out there for that.
It's heavily referenced. There's really nice flow diagrams on a lot of the pages where it gives you if-then treatment decisions. So if it's stage 1, do this. If it's stage 2 or above, do this, and takes you through treatment paradigms in a really nice, logical way. So that
it will be intimidating the first time you look at it, but
yes.
just look at it with somebody who knows what they're doing, because you just have to find the parts that you actually need to look at. If you just try to look at 300 slides, you're going to be overwhelmed.
Yeah.
Well, thank you guys. I really appreciate you doing this. And I think it's been another great medicine topic that we've gone over.
Appreciate it, Grant. Thank you. Thanks, team. And yeah, if this comes out before AMIS, come say hi, and hopefully see you at the St. Louis course and let us know. I've been getting a lot of emails from wonderful listeners out there, and it's so wonderful to hear, folks that appreciate this and it's helpful in their learning and lives. So please let us know those things, because sometimes we do these and we don't know if it's helpful, but we'll keep doing them to try to help everybody's learning and grow better as a profession. And Max, can't thank you enough for, being such an expert and willing to come and spend your time helping, some teeth slog and oral surgeons understand some liquid malignancies better.
It's such a pleasure. Really always appreciate jumping on to chat with you guys. It's really, really fun, and hoping we can do this again in the not too distant future.
Thank you so much for listening to this episode of Everyday Oral Surgery. For more information on these podcasts, please visit everydayOralSurgery.com. I love feedback and would be very grateful if you would reach out to me via my email, grantstucki@gmail.com, and let me know what you thought of this episode. Or you can text me at 720-441-6059. Additionally, if you have any topics you'd like to hear about, or if you would like to be a guest on the podcast, please email or text me. I found many of my interviewees through people who have been contacting me and have been listening, and I've gotten so many great ideas for more podcasts, and that's what helps keep the podcast rolling. So I really appreciate you making that extra effort and helping me out with feedback and knowing what to do next on the podcast. Thank you so much.